Okay, so today we're going to do some lymphatic facilitation and some neuromob techniques. So first off, for the lymphatic facilitation, we're going to identify the terminus, and it is located right underneath their clavicle. So we'll have the patient expose their chest a little bit. And so what you really want to do is, it's kind of right underneath this clavicle. So when you're performing the L strokes, you want to kind of get underneath there and then just perform L strokes like this. And you're just really barely even moving the skin. You're just trying to get that first layer of lymphatic drainage to go. Always trying to go proximally back up towards the head. And you can even get with both fingers, as long as the patient's comfortable with having your hand over their neck. If not, then we can just do it one-handedly. And thumbs are usually the technique to use for the terminus. Next, we're going to just explain the strokes that I'm doing. They're called L strokes, and the whole purpose of an L stroke is to just get that drainage back up into the system. So if there is a cut or an abrasion, let's say there's a cut or abrasion right here, and we're not getting much edema reduction back, you want to do some of this. So if the cut runs along here, you want to start distally first, and you want to do long strokes. So long L strokes all the way up. And you can do this with the pads of your fingers or even the pads of your thumbs, and you want to just pull and release. You're trying to open a door essentially and close it back. So you want to do that all the way along the cut, even on the other side, just like that. And some indications for doing these lymphatic facilitations are such as you're not getting enough edema reduction, or there's still edema present, maybe even some ecosmosis. You just kind of get that fluid back up into the body. Contraindications, if they've got no malignancies or even like signs of DVT, blood clots, you don't want to move that fluid up into the body. So the next one we're going to do is we're going to do some neuromobs, and we're doing neuromob for the peroneal nerve. So we're going to do it on his left leg, and first off, you just want to get this right leg nice and relaxed. So we're going to have him place their foot on a chair, a stool, maybe even like a couch if it's up nice and good relaxed level. So we're going to nice and relax that right leg. I'm going to have the patient sit up for me, and then we want the patient to already assume the slump position, so the curled shoulders, neck flexion. So as you can see, this is pretty high with the knee. I mean, the knee's popping out pretty good, so we want to work on that first. So all I'm going to do is grasp the foot, and I'm going to try to just push that knee down into full extension, and the patient should be feeling neurological symptoms, numbness, tingling, any sort of that up through their leg and then the back of their knee. And so to first get rid of this, we're going to just pump the knee down, and this is sort of pumping, sliding this nerve back and forth through the body, and it should be relieving those symptoms when we be talking to our patient and asking them if they feel okay. And then when we move away from that, we're going to go down to the peroneal nerve, which we want to assess. And so the first step is to get them into some dorsiflexion and inversion, and then with that knee extension as well, and we're going to pump as well. And then if they're not feeling this, then you can even add more dorsiflexion and then come back and forth like this. So we're really getting that lengthening and then shortening of the peroneal nerve right here. So you want to do this about 10 times or so, or until the neurological symptoms go away. And this will help relieve the sensation of tightness. So some indications would be obviously the neurological pain, the feeling, sensation of them tight when they're actually not tight. Contraindications would obviously be like deformities, fractures. If the patient has complained of other sorts of tightness. You don't want to do this if their hamstrings are actually tight. And then, yeah.
For the final task for this video, we'll be doing the upper extremity sweep mobilization for the ulnar and median nerve. And some contraindications and indications are basically the same for any neural mode like previously mentioned. So all you have your patient do, I'm going to be the patient, so you have them go into like a little preacher stance and then just back and forth to the end point as far as they go. If they get numbness, tingling, pain, this can be a positive sign for some sort of neurological pathology, or even just neurological nerve tightness. So you have them do this for a good while until their symptoms go away. And yeah, that's about it.